Hey friends, and welcome back to the Healthcare Wayfinders podcast, where we are routing you to more accessible and cost-effective healthcare. Today, I'm thrilled to share my conversation with Michael Hennesey, founder of Diathrive. Michael's team is tackling diabetes care from every angle to improve affordability, accessibility, and outcomes. In today's podcast, we'll uncover how Diathrive provides low-cost diabetes testing supplies for individuals, runs impactful diabetes management programs that improve employee health while saving employers money, and an exciting new GLP-1 management program that they've designed to help patients succeed with these medications. This is a conversation that you won't want to miss. Let's dive in. Michael, thank you so much for coming on the Healthcare Wayfinders podcast. Why don't you tell the audience a little bit about Diathrive and what it does, and then we'll get into the how and why you founded it.
Yeah, so Diathrive is a diabetes management solution for health plans. We have health plans as well as like self-funded, employer-sponsored health plans. And it provides for the individual essentially unlimited clinical consultations with our health advisors that are all at least RNs and certified diabetes care and education specialists. And some of them have other degrees beyond that. And then unlimited testing supplies. They can test their blood sugar. And then an app where they can self-educate, share their data, and serves as the hub for scheduling, shipments and clinical consultations. So, and then for some customers, we also facilitate continuous glucose monitors as well. That's kind of the core service for the individuals. And from the plan sponsor side, we upfront do a claims analysis that we work with Milliman to refine. And that essentially gives the plan sponsor an idea right from the beginning. And, it takes in pharmacy and medical claims data. And then we'll tell them, hey, here's what your population looks like in terms of the number of people with diabetes. And then of those people with diabetes, how many of those people are actually managing it.
Okay.
And so then that's kind of the benchmark that we use going forward. We want to try and improve the number of people managing it. And then, of course, through our service, we're collecting clinical data, and we kind of use that as a benchmark going forward as well.
That's cool. So if I'm understanding it correctly, you're providing value to the actual users to help them better manage their diabetes, which means they live a better life. And then from the employer's perspective, you're helping them to have a more healthy employee population, and especially those that are self-funded. Hopefully that means they're going to be have to spend less money on care overall. Is that correct?
That's right. Yeah. And it's also helping the plan sponsor just really kind of do their diligence on their own population. Because we found that a lot of the other kind of services that are out there are fairly high level. And when they drill down on something like diabetes, it turns out that a lot of the data that they're getting is not super accurate. Number two, the other interesting thing is that because, from 12 years ago now, from the Affordable Care Act, a lot of people have essentially been pushed out of, or really are functionally uninsured. And so, I'd say, Diathrive kind of attacks it from two areas. One is the plan design, and one is the actual provision of benefits, right? And from the plan design perspective, I think we almost every one of our clients that launches, they'll say, well, I have 100 people with diabetes or something like that. And fairly quickly after launch, they find out that it's actually quite a few more than that who just have been really, like I say, functional. I mean, if you have a $5,000 deductible and you're a teacher or, have any other kind of normal salary job, gosh, that's a really big deductible. And so things like diabetes that maybe are the chronic conditions that are kind of longer term type things that don't cause you pain in the moment. It's not a broken arm. A lot of people tend to push off that care. And so we almost always find that the way the population looks at 3 months in is a lot different from at launch, because we fix a lot of those kind of plan design issues where people have been pushed out of their plans because of the costs.
Yeah. So you're saying that because you're making diabetes management more affordable, you wind up having more people participate in it and therefore are healthier and living better lives. Is that correct?
That's right. Yeah. Sometimes many more people, just depending on the plan design and the deductible and things like that. So all of our benefits are 100% paid for by the plan, and the individuals pay nothing.
Wow.
And so, whereas previously, gosh, I mean, just to get to a certified diabetes care and education specialist under most plan designs, or going to a primary care, and to do that, of course, you have to make an appointment, and you've got to pay a copay, go wait in the waiting room, pay a copay, go in and see the primary care. Primary care says, yeah, it's got diabetes. I'm going to refer you to an endocrinologist. Sometimes, right? A lot of times the primary care will just try and manage it themselves. But then if you go to an endocrinologist, you've got to call. The average waiting time in this country is 3 months to get in to see an endocrinologist, just to get in to see the person. And then you've got to wait in the waiting room and pay a copay. And then the endocrinologist, if they have a relationship with certified diabetes care and education specialists, they'll also refer you to them. Usually can't see them the same day. You've got to call, you've got to wait, then you've got to, go in on the day of your appointment, pay a copay, and talk to them. And so, gosh, just that hassle alone, the administrative hassle, right, of calling and making reappointments, especially if you're a busy working parent with kids, that alone can be a disincentive and just kind of push people away from doing some of the baseline things that they ought to be doing to manage their diabetes.
That is really cool. So I don't have diabetes, but my wife is a nurse practitioner at an endocrinology practice that serves primarily folks with diabetes. And she talks about this same difficult journey for the patients that you just described. And, I hear the frustration from her all the time, wishing that there would be some way for the process to be easier for folks to actually engage, right? Because it can be, at least from what I've heard from her, between the cost and then the management hassles, like what you're talking about, it can really disincentivize people to take a proactive, approach to managing diabetes, because they're just running into roadblocks everywhere.
Right.
Yeah.
Yeah. Well, that's interesting. You have that personal background. That it's really, what's also, I think, really curious about healthcare in general is that it tends to be looked at as like things on a whiteboard, deductibles and copays and network structure and benefit structure, plan design. But, that's fine. I guess that's one valuable thing to do, to look at it that way. But man, when you start living it, it's just a totally different experience, right? Mm-hmm. And the guy who sits next to me is type 1. My best friend from high school was just 5 or 6 years ago now, was diagnosed, in his 40s with adult onset type 1. Almost every person that I've ever met, even with type 1, has just a horrible story about, usually involving misdiagnosis. Another fellow here, his son-in-law, same thing, just recently misdiagnosed with type 2. Turned out he had type 1, was, given the wrong medications to take, told the wrong things. This happened to my best friend from high school too. So yeah, it's, once you have the personal background like you do, boy, you start learning all these things, and it's, you just think, why is it structured this way? We really can do a lot better than this.
Yeah. Well, I think what you're just talking about there really leads us into what's the why of Diathrive, and why did you guys start it, and how did it come about? Because it sounds like it probably came from your personal experience and those around you.
Yeah, it was pretty simple. I was running a diabetes company that was part of just traditional healthcare. And we had an accredited diabetes education program. And gosh, I just watched, and talking to people at diabetes support groups and watching thousands of patients on their journeys. It was just amazing. I mean, the efficacy of those programs, the engagement in those programs is so low all across the country. And, my wife's an educator, and a lot of folks in our extended family are educators. And it's an interesting phenomenon, right? In education, we blame the educators when the students don't learn, and we pass things like No Child Left Behind, and, and we blame the educators. In healthcare, when the people who are receiving products and services don't do things, we blame the patients. And all across the country, when you talk to people who administer diabetes programs, they will almost to a person blame the people, the patients, for not doing the things that they tell them. And, you know, gosh, as we were starting Diathrive, I heard a guy named Bill Polonsky speak, who's really our clinical guru. And Bill, he's, been doing this for 4 decades or so and has diabetes himself, and is really the number one person in the world on why people don't follow chronic disease management programs. And he's been on the clinical advisory boards of a lot of diabetes related companies. And he kind of just and I heard him speak several times and just thought to myself, this guy really gets it and understands what's wrong with these programs. And then that kind of just all played into how we started Diathrive. And it really comes down to the fact that, like you say, and like it sounds like your wife has told you, there are really barriers to people doing things all throughout the healthcare system. They're financial, they're administrative. And one thing that Bill really illuminated for me are the psychosocial reasons. That has to do not just with the patient's psychosocial approach to things and determinants of health, but also the way that clinicians are trained in this country and how they approach patients. And some of that has to do with the structure of the healthcare system, right? Where most people are in kind of a fee for service model where they only have, and most patients, if you talk to them, how much time did you get with your endocrinologist? It's usually about 3 minutes, that they spent with them. And so diabetes, as your wife's probably told you, can be very complicated. There's a lot of different permutations of the condition. And so that really is why we started Diathrive. Was I just thought, gosh, we can make this simpler, easier, better for both the plan sponsors and the patients who have diabetes who are covered by these plans. And so that was, gosh, in 2016, I think we opened our office. So 8 years ago this month.
Wow. Congratulations.
Yeah. Thanks.
That's awesome. So anybody who manages a health plan or a self-insured business or organization, they should definitely reach out to you. What does your offering look like for just direct to consumer folks who are going to find out about you through this podcast and they either want to use your services or recommend it to folks that they know? How does that work?
Yeah. So, like you say, the health plans generally bind us through because they know that they have a problem with diabetes. They want to get more people engaged with diabetes. Well, we do claims analysis up front, and then we'll guarantee savings to their plan based on that claims analysis. And I have tons of case studies and a track record now of getting a lot more people engaged in managing their diabetes. The direct consumer folks hit us just directly through the website, and the offer there is basically just higher quality testing supplies at lower prices. And, we've been tweaking that over the years. That's been an interesting case study and really, plan design. I mean, on that side of the business, for example, 20 to 30% of the people actually are on Medicare, but can't get Medicare to cover enough testing supplies for what they need, which is crazy when you think about it. That includes veterans, speaking of veterans today on Veterans Day. And then another 25% of them or so are underinsured, but a lot of them just don't have insurance that covers testing supplies.
Wow.
So that's the direct consumer side of the business.
Okay. So folks can get on your website, which we'll provide a link in the show notes, and they can sign up for your product. It's sort of like a membership, right? Where they sign up for how much testing supplies they want on a time period, and it gets delivered to their door. Yeah.
Right.
That's great. So definitely everybody check out Diathrive in the show notes. I've got another question for you, and it might be, I'm not sure if you guys are into this, but the whole explosion of GLP-1s, right? And how has been around for a while, right? I think my wife and I listened to the WSJ's podcast series about GLP-1s, and they've been around for 7 or 10 years. She's been prescribing them for a while, but now, they're this new hot thing in the market. Maybe speak to kind of, again, sort of the healthcare consumer audience here, but Are you guys involved in that at all? Or how do you see that affecting kind of, the industry going forward and how people's care is going to be?
Yeah, we are actually just at this moment launching a GLP-1 solution because so many of our plan sponsors have been concerned about it. You can see the impact on plans. Some of the interesting publicly available data if you go and look at the Texas retirement system, they have publicly available data right off their website. Their spending on GLP-1s went from like low 200 million to over $400 million in just 1 year.
Whoa.
From 2022 to 2023. We're hearing the same thing happen all over the country. We've got over 600 health plans that we work with, and we're adding more constantly. And every single one of them has had a problem with GLP-1. So I'm glad you raised it. And I'm glad that you have that background. Again, that's really fortunate with your wife talking, because they're not new, but you would almost think that they're new, given some of the news stories and publicity around them. I think, the core issue for plans with GLP-1s is really, are we going to cover them or not? And then if they want to cover them because of the demand from consumers, then the problem becomes, how do we manage this? And the state of Texas is, just one example, but every health plan in the country sees this happen, where they go in and there really isn't an effective system for figuring out, for regulating this. And the way that as you and your wife know, the way that the healthcare system is set up, people go in and ask for a script. The doctor doesn't want to lose the patient, unless it's really contraindicated for some reason, physicians are really willing to give prescriptions. And so that has caused an explosion in costs for health plans. What we're doing is kind of applying the same principles that we applied to diabetes management, in terms of trying to remove barriers to people, but also get people engaged and accountable in the process. And so in our GLP-1 solution, it's a way for plans to really make sure that the people who are getting GLP-1s have a medical need for them. Our service starts off with an at-home blood test that somebody puts on their arm and then returns, and within a week or two get results back that are reviewed by a physician to make sure that they don't have any of the things that, would contraindicate GLP-1s, that they qualify. If they, on a blood test measure, qualify and look like they'd be a good candidate, the physician actually does an interview, a live, Zoom interview just like this with them to talk through. It turns out that after you look at just the cost of GLP-1s, the next really big problem is discontinuation rates. And your wife will probably tell you about this. There was just a study published in May. The data that was talked about at the American Diabetes Association scientific meetings found discontinuation rates of over 60% on Ozempic, and on the stronger classes of GLP-1s, over 80% discontinuation rates after a year. So the problem with that, and what we're hearing from our health plan customers, is that, they pay a lot for these medications. As you know, they can spend, $2,000-$3,000. I read a story in the Wall Street Journal about, Hollywood stars that were paying $3,000 a month for these types of medications, right? So they're spending, $20,000 for these medications for somebody. And if they then discontinue it after a year, what we're finding is that people end up putting on, first of all, they've lost muscle mass. And then within 3 to 6 months after discontinuing them, they end up putting on more weight. And so our health plan clients are coming to us and saying, I just spent $20,000 to make my member sicker. And what can we do about that? And so to get back to our solution, in the interview with the physician is going to, kind of tell the person what to expect, and of course we're applying FDA criteria to the blood test, and the physician's making sure that they have a medically necessary condition. Because if you look, by the way, now on a lot of our populations, over 40% of people would qualify for GLP-1s just on a BMI standard. And now you and your wife have probably seen it. They're getting approved for Alzheimer's and ADHD, and approved for adolescents and things like that. So that the range of people who could potentially be on them, and they're really designed that these medications are designed for people to be on them all of their lives. So for health plans, this is just a financially catastrophic increase in cost for people. And what our solution is trying to do is say, hey, let's apply some FDA criteria upfront. Let's upfront give people training so that they don't discontinue them. And then on an ongoing basis, we actually proctor, and our health plans will only cover these medications if the members, at least 75% of the time, do proctored injections. And what that means is that a Diathrive proctor is on the phone with them, verifies their identification, verifies that they're taking the right medication, and has them step on a scale, records their weight, and then actually watches them inject the medication. And of course, can talk to them about, hey, what symptoms are you having, and try and head off the discontinuation rates so that, so they know what they're getting into up front. And then as symptoms evolve, because as I'm sure your wife has told you, that the titration schedules on these things are pretty dramatic, and you can have pretty dramatic changes month to month based on the increase in your dosage. So our proctoring service is designed to kind of catch those things and help the member with the side effects that they might be experiencing, and try and help them get on a healthy, path with GLP-1 so that they don't take them and then just drop them cold turkey and have wasted all that personal effort by the member, and of course wasted the plan's money during their journey. So that's kind of that's the way that we've approached GLP-1s. But yeah, I don't know that people appreciate how the impact that it's having on health plans. I mean, it's really very dramatic all across the country.
That's so interesting. I should have done this at the beginning, but for our audience, GLP-1s are like Ozempic, are medications that have been traditionally prescribed for folks with diabetes and some other healthcare issues, and that help them lose weight, which helps with their different conditions, make them more manageable. That's a huge generalization, but they're becoming more used basically as a weight loss drug. And kind of connecting back to what you were saying, my assumption with the cost increase is that, and you said it before, lots of different people are asking for these drugs. Doctors are in general giving them prescriptions for them, which is driving up the costs. You were talking about the rate that people stop taking the drugs. Do you have data on, is that a side effects thing? Is that a cost thing? Why would people, if a drug helps people lose weight and feel better, quote unquote, why would people stop taking it?
Yeah. And I think that you hit the nail on the head. I mean, I think the big two reasons that are cited is cost, because they're hugely expensive medications, and then just patient dissatisfaction is the broad category that I saw in the American Diabetes Association scientific meetings. Like I say, the titration schedule is pretty steep. So people go from, 2.5 milligrams to 15 milligrams pretty quickly. And so if they don't have kind of guidance along the way beyond just periodic, fee for service doctor visits, and if they don't have, resources that are readily available without a lot of the barriers that we talked about at the beginning, it can be a rough journey for people. And, the thing that we found anecdotally is just that the range of, it's not just like diabetes itself. The GLP-1 journey is not really the same for every person. For example, we have a health plan where two of the senior leaders of the plan are both on Ozempic, both been taking it for over a year. Neither one of them has lost a pound. Neither one of them has seen any difference in weight. And I was shocked when they told me that they were taking them, because they don't look any different. But their blood sugar has gotten under fabulous. They both have type 2 diabetes, and their blood sugar control has been fabulous as a result of them. On the other hand, I have, my own barber over the last year has lost 120 pounds.
Wow.
Right. Taking Ozempic, and, it's changed his life, and he's been very diligent about making some lifestyle changes, which is the other thing that our service tries to promote in people. Because I think if you try to maintain, your same diet and kind of same routine, and think that you can just take GLP-1s, your chances of not being able to continue the medication are really high, because, it causes some paralysis of the digestive system. It slows it way down. And then you have a feeling of, they call it satiety,
You're
of being
full,
satiated.
faster, longer. Yeah.
Yeah. You feel full faster and then for a longer period of time. And so, there are certain foods that you don't really want that feeling if you're eating them, right? You want those foods to go through you. Um, so those types of things are behind the discontinuation rate. It's cost, and then it's the side effects. And frankly, the other thing I think that plays into it is for people who are not on a service like ours is the shortages across the country of endocrinologists and primary care physicians. If you're only talking to somebody every 90 days about this medication and you're on the usual titration schedule, that can get out of control really quickly. And, then you stop it and, you got to wait a couple of months to get in and see somebody.
Mm-hmm. Yeah. You talked about it briefly on your program. What's the process that you help take people through who are on GLP-1 so that they have a better experience and maybe are set up for more, long-term success? Because that was one of the things when my wife and I were talking about it of, these can be incredible tools, but at the end of the day, they can't change the underlying causes of what's going on. So how does your service help folks who are on GLP-1s have a more successful journey, I should say?
Yeah, there's 3 or 4 things. Number one is just upfront, the education upfront. Why do you want to be on a GLP-1 and what are you expecting to get out of it? If you're just trying to lose 10 pounds, I don't know, for the summer to look better on the beach or something like that, that's probably not a good reason to get on a GLP-1. And then but for people who do qualify, then it's an education of, well, here's what you should expect from the side effects. That's the second thing. And like I said, understanding that just because your neighbor had X experience with GLP-1s, that has nothing to do with your experience. And there's a pretty long list of potential things to look at and think about and to stay in close touch with somebody about. And then the third thing is just doing the proctored weekly injections, I think is really important, because then the proctor can keep tabs on what is happening on a weekly basis as dosages might go up or potentially have to come down depending on what's happened. And then the fourth thing is, again, getting back to structural healthcare problems that we have is, hey, if somebody talks to one of our proctors and they have a problem, and we have them do a brief written thing too every week just to clue us into some things. But then when the proctor talks, so if they have a medical issue, they're talking to a physician right away. And so, just trying to, again, make healthcare easier, faster, better, more intuitive for people, right? I mean, if you have a problem these days, like my friend here's son-in-law, the primary care told him to go see an endocrinologist. Then he found out that it was 7 weeks until he could go see the endocrinologist. I mean, it's like that doesn't really work very well, especially when you're on medications like this, where some of the side effects can be really dramatic and uncomfortable for people.
Mm-hmm.
So those are some of the ways we try to address GLP-1s with people. And again, part of it's just providing resources to people, immediately hacking the existing healthcare system. But, on the other side, we have the financial data to show the plans like, hey, this really makes sense for you. You can either just give everybody a GLP-1 and, let them have at it, or you can have a more structured kind of curated experience for people that, gives them a better chance of being successful in the long term. And of course, it turns out that if you're wise about how you invest healthcare dollars, that's how you think about things, right? Is over the longer term. And you think about things like engagement rates and the efficacy of the overall program. So we've been fortunate to partner with and find a lot of people across the country that are really tired of the traditional kind of big healthcare monopoly driven approach and broker approach, and who are structuring taking charge of their own benefits and looking at data and want to do the right thing for their members, which, and in our case and in a lot of other cases with other conditions too, doing the right thing also is the better thing financially for the plan, it turns out, which is one of many paradoxes in healthcare.
Yeah, which hopefully would drive down more costs, right, for the end
Yes.
users, healthcare consumers. You said that this GLP-1 program that you have is primarily here at launch for plans. Are you planning to have a direct consumer option, or how would somebody who's just, a healthcare consumer, are they able to access a tool like that?
We haven't launched anything direct consumers. And just to be clear, we're just in the process of doing some beta customers with this on the plan side. And the reason why we haven't been able to or wanted to get into the business on the consumer side is just that we have partnerships with pharmacy benefit managers. And as you know, they're one of the most powerful, interest groups in healthcare. And we have a solution that saves plan money and provides a better member experience, but it requires some discipline on the side of the plan. For example, if somebody's going to get a GLP-1, they have to come through Diathrive Health to get this kind of curated experience that I described. When we don't have those kinds of controls on people to where we're getting claims data, we're knowing what they're doing, it's, which we don't have on the direct consumer side, it's a lot harder to come up with an experience that I guess that aligns with our values of really trying to provide value and efficacy for people. It's just harder when you're not kind of connected to the back end of a health plan and can track people and they get more data in.
All right. So it sounds like the answer is pay attention to your healthcare benefits and look for Diathrive, because you're gonna get some real value there. Before we end, I always like to ask folks, what's y'all's big, hairy, audacious goal that you want to see happen in 5 to 10 years? What are y'all going after? What do you want to see different in healthcare?
There are a lot of things I want to see that different in healthcare. Diathrive's goal is to get 1 million covered lives here in the next 3 to 5 years. But I think that as we've been evolving, the big trend that we're seeing is that I think that particularly as some of these AI-driven tools come on board for us getting data from our plan partners, I think we're going to see a much bigger ability and we're working on this now, ability to connect people's everyday decisions, and not just the members, but also the plans, connect their decisions with the risk in the population. Because, for example, one of the things that caused us to start Diathrive was just this realization that, wow, these simple things that people can do to manage chronic conditions, there's no reimbursement for those things. Your wife would probably tell you, I was living in Central Florida at the time, and all across Central Florida, they were shutting down these diabetes education programs. And a lot of times they're using the extra space to put in cardiac beds. And so there was just no reimbursement. And so in some ways you can't blame the healthcare systems for shutting down these programs, because the reimbursement is almost nothing, but the reimbursement for the heart attacks and the strokes, to which diabetes is a main contributing factor, are through the roof. And that's what drives the bottom line for these hospitals, unfortunately. And so I hope that as we get better, and things like the CAA, the Consolidated Appropriations Act that was passed in 2021, have made firmer and made more explicit the responsibilities of the fiduciaries managing these plans. I hope that now that they know that they've got an obligation to look at their population, to understand the data of their population, and then to bring in solutions that address their population needs. As we get in more data too, we'll start to see, well, this is what happens to a person for whom you don't have great services like Diathrive that really are best to start when you don't have symptoms, when you don't have really bad symptoms, right? Because once you've progressed kind of along the continuum of care of diabetes, and there's a point in which you can get just too far down to where there's really not a lot that we can do. You're having limbs amputated and all these, terrible health outcomes that are terrible physically and psychologically in lots of other ways. Whereas if we'd started, all the way back at kind of at the beginning of the journey, you could just make a few little decisions that would have a massive impact down the road. So I hope that, and we're working to incorporate data into our solution in a way that we can make that explicit for plan sponsors and show them, hey, these things won't just save you money in the present day, which we currently do for health plans, but also that by getting more people engaged and managing their diabetes, that is the right thing to do, today for out in the future. Because if you think about it right now, a lot of these health plans are structured almost explicitly, and especially when you're talking about high deductible plans, right? There's incentives in place to where we're really just foisting all of these problems onto Medicare and Medicaid for when people stop working. And really the way that we get healthier as a country is if we pull more of the data in to be able to show, yeah, you're here, but here's where you're headed in terms of risk, because risk in healthcare essentially equates to cost. And so that's kind of some preview of coming attractions in the next 2 to 3 years that we want to come out with too, are taking all the data that we've now gathered from hundreds of plans and thousands of people and working that into our solution so that we can work with the plans to even further incentivize and focus members on, making a few better and helping them make a few better, healthier choices today so that they're healthier over the longer term.
That's awesome. Well, Michael, thank you so much for coming on the Healthcare Wayfinders show. Appreciate all your work helping to make diabetes testing supplies more affordable and accessible, and here soon helping people have a better experience on GLP-1s. So thank you for coming on the show.
Thanks, Zach. I really appreciate it.